Hello, friends. I'm back with lots of greetings for Merry Christmas and Happy New Year together. Today, the topic is birth injuries, understanding the causes to avoid calamities. This is important from the practical point of view. Also, there can be a theory question for PGs on birth injuries. So, I've tried to include almost all the types of injuries so that you can write a nice essay question. And tomorrow, I won't be taking any class on the occasion of Christmas. Let's enjoy the festivities. What's the definition of birth injuries? Birth injury is an impairment of the neonate's body. Structural impairment or functional impairment. Both are included. Due to an adverse event that occurred at birth. Very simple. Definition always defines the tone of the lecture. So there has to be a structural injury or there can be a functional injury due to an adverse event that occurred at the birth. Injury may occur during labor, delivery, or after delivery. Labor, of course, baby is inside the uterus. So it's basically a ischemic injury to the especially CNS system or maybe respiratory system or cardiovascular problems. Delivery, of course, the use of instruments, especially, or maybe a forced delivery and causing fractures or causing nicks on the baby's face or body when you give episiotomy, or even after delivery. Sometimes we have heard the obstetrician or nurses have dropped the baby down. That's very scary. Other than that, there could be other injuries as you are trying to give oxygen, 100% oxygen, or you are trying to, forcibly intubate the baby. There could be pneumothorax. There are so many things that can happen during labor, during delivery, or after delivery, especially in units who require resuscitation in the delivery room. So the spectrum of birth injuries include minor injuries, and they are self-limited problems. For example, laceration or bruising. Even if you don't treat really aggressively, they will heal on their own. Bruises will come down on their own. Two, severe injuries that may result in significant neonatal morbidity or even mortality, that is spinal cord injuries, for example. The incidence, thankfully, is very low, 2 to 3% only. The scalp injuries are the commonest, as I said, either during giving episiotomy or even at cesarean section. If you are a little aggressive, then you may injure the scalp. 80% of these birth injuries are scalp injuries. Lacerations and bruising, especially if you are using vacuum or forceps. Major trauma constitutes 20%. It could be fracture, neuronal injuries, extra and intracranial hemorrhage, hypoxic ischemic encephalopathy, and seizures. What are the risk factors? They are very, very obvious. Increased risk of birth injury can be either due to fetus itself because of its size, big babies, or extremely small babies, and presentation, the malpresentations or breech presentation. Lots of injuries occur during assisted vaginal breech delivery. Even in cephalic presentation, if you have not assessed properly, there could be shoulder dystocia, and at the time of manipulations, there could be injuries. Mother, of course, size and presence of pelvic anomalies, contracted pelvis, for example, or anomalies in the pelvis, distorted pelvis, these are the ones which cause injuries to the baby. Then, instrumental delivery. It is very, very obvious that whenever you use vacuum or especially forceps, there could be a lot of injuries. Risk factors that increase birth injuries are macrosomia, as I just now talked about the big babies, weight more than 4,000 grams. So again, further dividing 4,000 to 4,499, there is 2-fold greater injuries. And as the weight increases, it is 3 times more, and more than 5 kg, 4.5 times greater. You can even say 5 times more. And in general, it is something like 7.7% when the babies are more than 4,500. Again, in Indian scenario, we should not take international standards saying that up to 4 kg is okay because it all depends upon the mother. You don't go by absolute values in any situation. You have to always compare a given maternal pelvis to a given baby. So don't go by saying that macrosomia means 4 kg. I will try to deliver up to that by vaginal route. Even sometimes 3.2 kg baby may be very big baby for a short mother or a small build mother. Maternal obesity and BMI is more than 40 kg per meter square. Of course, this will increase the risk factors because mother, as we have I have talked in another talk regarding the problems with the obesity, it is most of the time they will undergo cesarean deliveries, maybe due to greater use of instrumentation or increased risk of delivering a large for gestational infant. Bigger the mother, bigger the baby. So altogether there will be a problem. Other factors like abnormal fetal presentation. This again I have already highlighted. Breech presentation is the commonest one, which will cause lots of three times more. I told you in another class of breech, everything is three times. Anomalies are three times more. The birth injuries are three times more. There are three, steps of delivery: the delivery of the breech, delivery of the shoulders, and delivery of the aftercoming head, like that. And there are three methods of delivering the aftercoming head also, right? So breech presentation is particularly has increased risk. Operative vaginal delivery, for example, forceps or vacuum delivery are associated with increased risk of birth injuries. The sequential use of vacuum extraction and forceps increases the risk of birth injury more than the use of either of the instruments alone. Of course, why I have mentioned is it is obsolete. Nobody should use sequential instrument. That means if vacuum fails, trying forceps, or if forceps fails, trying vacuum. It is very tempting for many gynecologists because they have promised the mother that I will give you a general delivery and they are stuck in their own ego or prestige. This is a big no. So I'm putting a no sign here. You should not use sequential instruments. If vacuum fails, don't hesitate to take her for cesarean section. Vice versa, if the forceps fails, again, take her for cesarean section rather than going for another instrument. What more? Other factors like increased incidence of birth trauma due to head and neck in male infants and babies born to primaries. So this is primarily mostly because of a missed CPT, and you again try to deliver somehow you are in obstetric labor situation. Small maternal stature, again a contracted pelvis, and the presence of maternal pelvic anomalies are associated with increased risk. Now, this slide is a little bit misleading or tricky. That's why I put a question mark. And green color means decreased, red color means increased. Decreased risk of birth injury, I put a question mark because this is the common thinking that if I did a cesarean section, birth injuries are less. It is unclear whether cesarean delivery is protective. The healthcare cost and utilization project nationwide inpatient samples showed cesarean delivery was associated with nationwide means not Indian nation, it's United States of America. Associated with decreased likelihood of all birth trauma compared to vaginal delivery. Adjusted odds ratio is 0.55 for cesarean to 95% confidence interval. However, when the analysis used the definition of birth trauma developed by AHRQPSI, that is Agency for Healthcare Research and Quality Patient Safety Indicator, cesarean delivery was associated with an increased risk of birth trauma. Adjusted odds ratio is 1.65. So you can see that. So that's why I put a question mark because I knew both the slides. So that's why I put a question mark. So the AHRQ PSI definition did not include clavicular fractures, injuries to brachial plexus and scalp, which are more frequently seen in vaginal deliveries. These findings suggest that risk factors between cesarean and vaginal delivery depending upon the type of birth injury, right? So there may be different type of birth injuries at vaginal delivery and totally different type in the cesarean delivery, but totally there will be birth injuries. It could be minor or major, but there are birth injuries at cesarean delivery also. Most of it is nick on the scalp. Now I come to classifying the injuries in a different way. The minor and major is one way. The other way is soft tissue injuries, and then the bones and intracranial and like that. So soft tissue injuries are basically the most common form of traumatic birth injuries are soft tissue injuries, including bruising and petechiae, especially patient has got the vitamin K deficiencies, and then the baby also will have these problems. Subcutaneous fat necrosis, especially when you have used forceps or vacuum, or if you have gripped the baby tightly. So subcutaneous fat necrosis is common. Lacerations all the time, not only forceps or vacuum delivery, even simple vaginal delivery, there could be lacerations. Bruising and petechiae usually are self-limiting, as I told earlier, and are often seen on presenting portion. Genitalia, bruising, and edema are common in breech presentation. Head and neck, petechiae, and head of the head and face are often seen in vertex and face presentation. Most often, petechiae are present at birth, then they will slowly disappear within a week. Not progressive, they are, and not associated with other bleeding issues of the baby. Most of the centers nowadays give vitamin K at birth, so that should take care of it. A platelet count obtained to rule out thrombocytopenia if petechiae continue or if other bleeding is present. Sometimes there will be congenital thrombocytopenia. That is the case which may have progression. Significant bruising has been recognized as a risk factor for the development of early and/or severe hyperbilirubinemia. Obviously, whenever there is bruising and hemorrhage, there will be hemolysis also, there will be jaundice. Close follow-up after the newborn hospital discharge is recommended. Coming to subcutaneous fat necrosis, it is uncommon and usually occurs in the first few weeks of life as a result of ischemia due to adipose tissue of the adipose tissue, often adjacent to bony structures following a traumatic delivery. Characterized by firm indurated nodules and plaques on the back, buttocks, thighs, forearms, and cheeks. Nodules and plaques may be erythematous, flesh-colored, and or blue. Typically, this condition is again self-limiting, with resolution usually occurring by 6 to 8 weeks. You have to have a lot of patience. Don't have to do anything very dramatic or very serious treatment is required. These infants require long-term follow-up for the development of hypercalcemia, which can occur up to 6 months after the initial presentation of the skin lesions. Lacerations, most common injury associated with cesarean delivery, as I said many times earlier. In a study of 3,108 cesarean deliveries, laceration rate was approximately 3%. 78% of them when done emergently, and most often on the presenting part, typically scalp and face. Majority were mild, requiring repair with just steri strips only. Hardly you have to suture them. However, 3 out of 97, that is 3%, were moderate to severe, located on the face or ocular area and required plastic surgery for repair. So after soft tissue injuries, I'll come to extracranial injuries. Head is the first one to come out, so there will be a lot of extracranial, intracranial injuries. So caput succedaneum is the one of the commonest, and this you don't have to do anything. It will subside on its own. Cephal hematoma is different, which is an active bleeding, but caput succedaneum is purely due to gravity. It's an edematous swelling of the scalp above the periosteum. This is very important. Above the periosteum, which is occasionally hemorrhagic, very occasionally. It presents at birth after prolonged engagement of the fetal head in the birth canal or after vacuum extraction. Vacuum extraction is, iatrogenic. It is like chinon, which is we ourselves create a caput succedaneum so that there will be a good grip inside the cup. So elastic cup will not have this, but the metallic cup will definitely have this. Unlike cephalhematoma, it extends across the suture lines. That's the difference between cephalhematoma and caput succedaneum. Because it is above the periosteum and it is across, right? Generally, a benign condition, it usually resolves within a few days and requires no treatment, as I told already. Whereas cephalhematoma is a subperiosteal collection of blood caused by rupture of vessels beneath the periosteum, usually over the parietal or occipital bone. So there you can see the clear demarcations, which presents as swelling that does not cross suture lines, like isolated islands of swelling. The swelling may or may not be accompanied by discoloration, rarely expands after delivery, and does not generally cause significant blood loss. However, there can be sometimes jaundice. Estimated to occur in 1 to 2% of all deliveries and is much more common with forceps or vacuum delivery. Ultrasound is useful for characterization of fluid collection, whether it is simple fluid like in caput succedaneum or whether it's blood collection, so that can be easily made out by ultrasound. CT or MRI will confirm the location and also be useful for evaluating the presence or absence of associated osteomyelitis. Cephalometry is a risk factor for the development of early and or severe hyperbilirubinemia, as I just mentioned. Close follow-up after the newborn hospital discharge is recommended in order to assess the jaundice. The majority will resolve spontaneously. Again, here you don't have to put an incision, drain the hematoma and all those things. It will only ask for infection over the course of few weeks without any intervention. Cephalometoma may resolve after, let's say, weeks, whereas caput succedaneum may resolve within a week. Now, after extracranial, I come to intracranial hemorrhage. This is more serious and more dangerous. Intracranial hemorrhage include subdural, subarachnoid, epidural, intraventricular hemorrhage, which is the most dangerous, intracerebral and intracerebellar hemorrhages. There are a whole lot of hemorrhages. The risk of intracranial hemorrhage, ICH in short, increases with operative delivery, obviously. Unassisted deliveries, it is 3.7 per 10,000, whereas vacuum assisted delivery is 16.2, almost 4 times, right? And forceps, again, similar, 17 per 10,000. 4 times more you can think of it. This may be an underestimation against 26% in spontaneous vaginal birth, as per a study that used MRI screening for brains and asymptomatic neonates. This is surprising, isn't it? So we think that spontaneous vaginal delivery may not have these injuries at all, but there can be injuries inside, because in spontaneous injuries, what happens is there is a sudden popping up of the head. If that happens, there can be cerebellar tears, cerebral Fox tears, and that can cause intracranial hemorrhage. Whereas that's exactly why, in extremely preterm babies, the baby can come out easily, but still we advise outlet forceps to have a controlled delivery of the head. The controlled delivery of the head is always better. What is mentioned in the upper point is that forceps deliveries have 17 per 10,000 is a difficult forceps delivery, not the prophylactic forceps where you deliberately use forceps to deliver the baby in a controlled fashion. I hope I have clarified these two issues. Subdural hemorrhage, SDH, although the incidence is rare, it is most common type of intracranial hemorrhage noted in neonates. Location is between dura mater and arachnoid membrane. The location of SDH is most often tentorial and interhemispheric. Risk factors are higher among infants delivered by vacuum extraction, forceps, or cesarean section. Presentation is seizures, respiratory depression, apnea, neurologic dysfunction, and altered tone and level of consciousness. These symptoms are common for most of the intracranial hemorrhages, so they are not totally different. So the differentiation is basically by a CT scan or MRI, imaging diagnosis by CT only. Management depends upon the location and extent of the bleed. If the bleeding is less, you can probably give conservative management. Most cases can be managed conservative therapy without surgical intervention. However, surgical evacuation is necessary with signs of increased intracranial pressure. SDH that occurs in the posterior fossa may cause brainstem compression that requires emergent surgical evacuation. Also, there can be death. All of you know that the coning into the foramen magnum can be very dangerous. Seizure disorders should be treated with anti-seizure medications simultaneously. Subarachnoid hemorrhage, the next one after subdural. It represents the second most commonly detected. I have put it in that order only: subdural, subarachnoid, neonatal intracranial hemorrhage, most often caused by rupture of bridging veins in the subarachnoid space or small leptomeningeal vessels leptomeningeal vessels. Although subarachnoid hemorrhage can occur with normal spontaneous vaginal deliveries, the risk increases with operative vaginal deliveries. As with subdural hemorrhage, newborns with subarachnoid hemorrhage most often present at 24 to 48 hours of life with same apnea, respiratory depression, and seizures. These are common. Diagnosis again by CT of the head or in non-emergent scenarios, MRI of the head. Treatment is usually conservative. Again, rarely a large subarachnoid hemorrhage can cause post-hemorrhagic hydrocephalus because these are small veins, bridging veins that are bleeding. Epidural hemorrhage. This is very rare in neonates and is found between dura and inner table of the skull, usually caused by injury to the middle meningeal artery. A rarity of neonatal epidural hemorrhage is attributed to the absence of middle meningeal artery groove in the neonatal cranial bones, thus making it more difficult to injure the artery. Thank God. Septal hemorrhage is often accompanied by, linear skull fracture and is usually located in the parieto-temporal area, this area, parieto-temporal area, often associated with operative deliveries and primiparous mothers. Epidural hemorrhage and cephalometoma can coexist when accompanied by an underlying skull fracture due to communication through the skull fracture. Presents with non-specific neurologic symptoms such as seizures and hypotonia. See, seizure is a common presentation of any intracranial hemorrhage, whether it is a subdural hemorrhage or a subarachnoid hemorrhage, epidural hemorrhage, including intracranial, intraventricular hemorrhage, hypotonia. So basically all nerve-related things. The diagnosis, same CT scan or MRI. Most of the undergraduates read CT scan and MRI and ultrasound without knowing. I mean, these are the only three imaging modalities. But you should know, I have highlighted CT is the best for these kind of diagnosis. Patients with very small lesions and stable clinical course may be managed with supportive therapy. Most of these intracranial hemorrhage can be managed by conservative methods. Given time, they will subside unless they are progressive or so large as to cause localization symptoms or respiratory problems or imminent death. There is no need to do any surgical intervention. Surgical evacuation is necessary when there is evidence of increased intracranial pressure and or the EDH is large. That's commonsensical, isn't it? Intraventricular hemorrhage. This is the very important hemorrhage. This occurs with or without instrumentation. It is usually common in extremely preterm babies, although IVH is usually associated with preterm babies. IVH is also reported as a consequence of birth injury in term infants also, but that's rare, 4%. The risk of intraventricular hemorrhage increases with operative deliveries. As you can see the stats, it increases. All the problems are increasing with instrumental deliveries. That's why nowadays many people hesitate to use instruments in that forceps. Vacuum looks simple, but we have seen vacuum also can cause intraventricular hemorrhage and blindness. One of the patients in Manipal had that, but these are reversible ones. That blindness that was caused due to vacuum, within 3 months it got resolved. Maybe there was some hemorrhage and that pressed on the optic chiasma or whatever, and that resolves on its own. So that's why most of the people now prefer, if there's any problem, to do cesarean section. But you should remember that cesarean section also is not totally void of any birth injuries. Intraventricular hemorrhage in the absence of a clotting disorder or severe asphyxia, um, most IVH in term infants will resolve spontaneously with no long-term sequelae. That's the beauty of it. For infants with IVH due to significant birth trauma, close monitoring is required due to the risk of extension of the hemorrhage into the surrounding parenchyma and the development of post-hemorrhagic hydrocephalus. Okay, so much about the intracranial hemorrhages. What are important there? Subdural, subarachnoid, epidural, and intraventricular. There are so many other types, but they are all almost same. They will have all neurological symptoms with the baby, and most of them is conservative management. Very rarely you require surgical intervention if they are very big and causing long-term problems or increasing in size, and simultaneous anti-seizure methods, medication also should be started. Earlier to that, we talked about the subcutaneous or sub fat necrosis and all those things. They are also very minor injuries. most of the time they will heal on their own, especially facial injuries. Wherever the blood supply is more, that will heal better. So there are no problems. Let's come to these facial injuries, especially nasal septal dislocation, because the beauty of the face is on the nose. So if you cause the septal dislocation, that will be a problem. But it occurs so rarely, zero point 0.6 to 0.9, because the cartilages are not so hardened yet. So that's okay. The delivery is due to the compression of the nose from symphysis pubis or sacral promontory is the cause of it. Infants with significant trauma can present with respiratory distress due to airway obstruction. This is more dangerous than the disfiguration of the face. The diagnosis is made by rhinoscopy, manual reduction by an otolaryngologist using a nasal elevator should be performed by 3 days of age. No treatment or a delay in treatment may result in nasal septal deformity. That's a problem. Ocular injuries, as I told you, minor ocular trauma such as retinal, subconjunctival hemorrhages, and lid edema are common and resolve spontaneously without affecting the infant in 1 or 2 weeks. Especially if the baby has been there for a long time, face presentations, there will be a lot of edema, lid edema, and other things. Whereas significant ocular injuries, that is 0.2% only, associated with forceps delivery and include hyphema, that is blood in the anterior chamber, vitreous hemorrhage, orbital fractures, lacrimal duct or gland injury, and disruption of Descemet's membrane of the cornea, and need prompt ophthalmologic consultation. Then comes the fractures. These are because of our heroic way of delivering things. So fractured clavicle. Sometimes fractured clavicle is deliberately done in a case of shoulder dystocia, either single clavicle or double clavicular fracture. This is one of the manipulations that we have to do to deliver to reduce the bisacromial diameter. Most commonly reported and ranges from 0.5 to 1.6. And risk factors are operative delivery again, shoulder dystocia, as I told just now, increased maternal age that again make the pelvis hard and shoulder dystocia more common, birth weight and lower HCAC ratio. Presentation is displaced completely immediately after delivery, crepitus, edema, lack of movement of the affected extremity, asymmetrical bone contour, and crying with passive motion is seen. But non-displaced varieties often delayed by days or weeks until there is a formation of visible palpable callus because of neonate is usually asymptomatic. When there's a fracture of the clavicle, sometimes there can be it can poke into the lungs and there can be pneumothorax. Diagnosis, just simple X-ray is good enough. No need of CT and MRI here. Management, because clavicular fractures in infants heal spontaneously and with no long-term sequelae, parental reassurance and gentle handling are all that are required. That's exactly why we don't hesitate to do clavicular fracture deliberately to deliver the baby in a shoulder dystocia. It will heal spontaneously. Analgesics may be given if the baby is crying. For comfort, the arm of the affected side can be placed in a long sleeved garment and pinned to the chest like this. Say I'm wearing a long sleeve garment, not for clavicular fracture, but because of the cold in Sikkim. So you can just pin it here is like this. So that itself is like a sling. Chest with the elbow at 90-degree flexion. So not till here, I'm showing it till here, but it is just a 90-degree flexion. Fracture humerus and femur, of course, this is again common long bone neonatal fractures, but as such are rare. Among the fractures, this is common, but fractures as such are rare. Reported incidence is only 0.2 per 1,000. Risk factors, again shoulder dystocia, macrosomia. Again, macrosomia causes shoulder dystocia. Cesarean delivery, you are trying to do Patwardhan's method, or you are trying to forcibly, remove the uh, femur or the humerus in a breech delivery. So low birth weight babies again, but in these low birth weight babies, the humerus and femur may be well developed, but the baby subcutaneous fat is low. That's why it is low birth weight. Presentation, decreased movement of the affected limb. Baby does not move at all. Decreased Moro reflex. and localized swelling and crepitation and an increased pain response with palpation and movement of the limbs. Baby will start yelling. So what you have to do? Diagnose by plain radiograph. In rare instances, a very proximal or distal fracture that is near the epiphysis, ultrasonography or MRI is more useful. Near the epiphysis. Treatment, immobilization again of the affected limb. Luckily, the healing is better, but you have to correctly position it, otherwise there could be malunion. With the elbow at 90-degree flexion for fractures of humerus to prevent rotational deformities. Parents should be reassured that angulation will remodel as their infant grows. Neurologic injuries, whole lot of injuries can occur during breech delivery. We have all seen that, waiters, hand, club case uh, injuries in the brachial plexus, most common in breech delivery. Phrenic nerve injuries often associated with brachial plexus injury. Clinical manifestations include respiratory distress with diminished breath sounds and affected site. Facial nerve injury occurs in 0.1 to 0.7 due to compression of the nerve by forceps or prominent maternal sacral promontory. Laryngeal nerve injury during birth may cause vocal cord paralysis. Symptoms include stridor, respiratory distress, hoarse, faint, and absent cry, dysphagia, and aspiration. These are all can be life-threatening, if you don't recognize and treat. So spinal cord injuries are more dangerous. They are rare, luckily, and incidence is only 0.14 per 10,000 live births. They occur more frequently in the upper cervical spine because of the greater likelihood of injury due to traction. If you try to pull the baby's head, there can be spinal cord injuries or rotation during the manipulations in the breech delivery. Injuries include spinal epidural hematoma, vertebral artery injuries, traumatic cervical hematomyelia, spinal artery occlusion, and transection of the cord. That's very, very dangerous. Risk factors include forceps assisted delivery and breech vaginal delivery. Then comes abdominal injuries, very rare unless the baby has got, ascites, or if you hold the abdomen and rotate the baby in case of breath. That's why I keep on telling femoro-pelvic grip. You have to hold the femur and the pelvis and rotate the baby in such a way that the back faces the baby. If you hold the abdomen and you are tensed up already, and those who have got long nails, they will definitely cause abdominal injuries. Like, they are literally tearing apart like Narasimha, Ugra Narasimha did for Hiranyakashipu. Intra-abdominal birth trauma is uncommon and primarily consists of rupture or subcapsular hemorrhage into the liver, spleen, and adrenal glands. This may happen in a hydrops fetalis. And presentation is dependent upon the amount of blood loss. Infants with hepatic and splenic rupture may present with sudden pallor, signs of hemorrhagic shock, and abdominal distension and discoloration. Whereas infants with subcapsular hematoma may have a delayed or more insidious onset of symptoms of anemia, which include poor feeding, tachycardia, and tachypnea. Unilateral adrenal hemorrhage may present as an abdominal mass. Risk factors are macrosomia, breech delivery, and use of instrumental delivery. Ultrasonography is best modality to diagnose. I think by this time you must have understood, name an injury, it's because of either a fetal problem, as I initially categorized, macrosomia being the commonest, malpresentation is the next one, in that breech is the common, which we dare deliver vaginally. All other malpresentations go for cesarean, but even there, since a lot of manipulations have to be done, there can be injuries. And then, of course, instrumental delivery, forceps and vacuum, and our forceful deliveries. These are the ones which cause injuries. And all injuries are most probably diagnosed by the symptoms, and fractures and other things are diagnosed by uh, X-ray, CT, MRI. Thankfully, most of them resolve on their own. Very few of them require intervention. Abdominal injuries, how do you manage? The management includes fluid resuscitation with blood products and normal saline, depending upon the amount of bleeding, intra-abdominal bleeding, as appropriate. Fresh frozen plasma may be needed to correct any coagulopathy associated with injury. In infants with hepatic and splenic rupture or who are hemodynamically unstable, laparotomy may be required to control the bleeding. Thank you so much. I thought this is a very like a odd topic, hatke topic. Most of the time, we don't bother to read about this. But unless you read and now you feel confident that you can write any injuries, head to toe, there can be injuries. And tomorrow, again, as I said, Christmas, Happy Christmas, Merry Christmas, and Happy New Year in advance. I'll come up with new topic on 27th. Thank you.